Hello and welcome to Addiction Science Outreach, where we provide lessons on addiction science. This is not medicine. We do not tell you what medications to take or how to take them. Only your individual healthcare provider can do that. However, we do try to help the general public and some medical providers understand the science of addiction. So let's take a look here at a few things. There were a few questions that came through academia that I think are important and I'd like to address. One was, is it possible to get off fentanyl and xylazine without the use of Suboxone? Of course, it's possible, right? It's some people are able to do it. Your chance of doing it is about 3 times higher with medically assisted therapy, meaning with Suboxone or methadone, than without. But it is possible, just less likely, much harder to do. Some people will think that you're trading one addiction for another, but that's not accurate. You're really trading an addiction for a treatment. At the same time, understand that methadone is a full opioid agonist, so getting off it is just as hard as getting off morphine, oxycodone, fentanyl, any of those that are also 100% opioid agonists, meaning that they completely bind and activate the mu opiate receptor. So buprenorphine only activates it partially. So there's reasons we'll get into as to why buprenorphine might be a better choice in some people. Remember, genetic variation makes this different for everyone. And another person says that they broke their back a few years back and that they're only in their 30s, a mother of 3 children that are under the age of 3, and that their doctor labeled them with opioid use disorder and is taking them off oxycodone and putting them on Suboxone, which they had a terrible reaction to. And now they're recommending methadone, which they're very afraid of. Not addressing these specific medical issues, but just in general, when it comes to these medications, understand that they all do the same thing. They all bind the opiate receptor and activate it, some more strongly than others. There's evidence that buprenorphine helps the mu opiate receptors repopulate in most people. And because it only binds, it binds very strongly because it only activates about 40 to 60% in most people. This is usually a better medication. It has a respiratory suppression ceiling, meaning that while most opiates can stop your breathing in high doses, the buprenorphine is not believed to do that unless you combine it with other things which you should never do. So a terrible reaction when going on to Suboxone. Now understand that Suboxone has Narcan in it. So if someone's on oxycodone and they go on Suboxone and there's still some oxycodone in their system, the Narcan will chase that oxycodone right off the receptors and they'll go from a full opioid agonist, 100% activation, down to the 40 to 60% that buprenorphine gives. And they can get very sick and it can hurt terribly and all that. There are also some people who just don't react well to buprenorphine. And that's because while it does activate the mu opiate receptor, 40 to 60%, it also activates the ORL-1 receptor, which can reverse some of that. So in some people, if their ORL-1 receptor is very active and their mu opiate receptor is less active, let's say that's, we're not going to get to the molecular biology of it, they might not tolerate buprenorphine. It might make them hurt. It might make them feel worse. The problem is, when you tell your doctor that a medication he's putting you on, especially one like buprenorphine, is making you feel worse, they are taught to automatically label you with opioid use disorder. It is a reflex, and asking for a medication by name is considered, drug-seeking behavior. And now, of course, if you've had oxycodone before and it worked well, and you're saying, hey, this worked better, you're just saying, I used to be on this and it worked better. But their response will be, you're asking for a specific drug, and that's considered drug-seeking behavior. Now, not necessarily by the doctor, but by the DEA. Understand that the DEA is prosecuting doctors and going in front of juries and saying, if the doctor worried about addiction, then the patient had addiction. Right. Now, the DEA doesn't say this themselves, though their agents sometimes testify about things that aren't accurate in court, but they pay people to do it. They pay MDs to get up there and say this. Some of them might honestly believe it. Some of them just don't know any better. And some of them just want the money and they don't care. And so be aware that the doctor is facing a minefield. There is no way to safely prescribe any controlled medication in the United States of America today. Any doctor prescribing a single medication can be prosecuted and convicted under the current nebulous rules that actually don't exist. There are no rules. There was one case where they told someone that they told a jury that the doctor prescribed Narcan, therefore he knew the patient was a high risk of addiction and should have stopped treatment. In another case, they said the doctor did not prescribe Narcan, proving that he didn't care if that person died of an overdose and he's a bad doctor. You cannot win. Okay, these are terrible times to have chronic pain or addiction in the United States of America, or to be a doctor trying to help people with these problems. So be aware of these differences and these issues, and understand that medication assisted therapy is not the same as trading one addiction for another. It's trading an addiction for treatment. And a good healthcare provider trained in addiction medicine can provide you this treatment. And some of them are willing to, though most are too afraid to treat addiction now too, because they've been arresting addiction doctors for daring to treat addiction, saying you prescribed too much or one of your patients sold it, so now you go to jail. Um, Doctors are not lie detectors, nor should we have to be. If you have to lie to a doctor to get a prescription, the doctor's not the criminal, the person who lies is. But right now in our current justice system, it's extremely easy to put doctors away. Right? And I want to make clarification when I was talking about Matthew Perry. I said that I subvocalized the not. Ketamine is not approved for the treatment of addiction. It is used off label for the treatment of addiction and chronic pain. And if you watch the case about the little girl named Maya, you'll hear the doctors talk very, very long and convincingly on both sides of the use of ketamine and not using ketamine. But quite often, if someone has neurogenic pain, it seems to give them relief. It can also help relieve depression. It's approved by the FDA for the treatment of depression when other medications don't work, so multi-drug resistant depression, and for depression associated with suicidal ideation, because it works much faster than the regular ones. And the SSRIs and SNRIs in some studies seem to indicate that they can possibly increase suicidal ideation at first before it gets better. That puts you through a high risk zone, and the ketamine doesn't do that. So if someone clearly has suicidal ideation, then ketamine in its S enantiomer form called S-ketamine is considered safer. So things to keep in mind. Thank you for the questions, and everyone have a good day.